The basic strategy that I've adopted, which is plan for the worst and hope, plan for the best, plan for the worst and hope for the best. This is basically what this video is about, is to anticipate some of the worst things that are going to happen from the COVID-19 and make preparations now. So I found some information about NLR, neutrophil lymphocyte ratio, that I wasn't really looking for. I kept noticing different publications emphasizing that particular marker, which it's one that we can calculate ourselves from our CBC blood test. So that makes it very attractive to try and use to either monitor interventions, like if we decide to use modified citrus pectin and honokiol at a 9-to-1 ratio. We can have our blood checked every couple of weeks or a couple of months and see if that intervention is having an impact. So what I'm going to do here is show some of the publications I found and read from some of the highlights. Now this one is from, let me see. So this is results. The neutrophil to lymphocyte ratio, NLR, was identified as the independent risk factor for severe illness in patients with 2019 nCoV infection. The NLR had a C index of 0.807. The calibration curves fitted well. And then some other statistical information but what they decided that NLR under 3.313 with patients over 50 and half of patients with age greater than 50 and NLR greater than 3.13. Oh, for the first part, it was 9.1%. But for the second one, over 50 and NLR greater than 3.13 would develop severe illness. Conclusion: the NLR was the early identification of risk factors for 2019 nCoV severe illness. Okay, so that's one that stands out pretty well because of the title. Neutrophil to lymphocyte ratio predicts severe illness patients. Okay, that's one out of the way. Now this is from, this is a systematic review and meta-analysis from June 2020. So they're saying in here, furthermore, we found that NLR as a novel marker of systemic inflammatory response can also help predict clinical severity in patients with COVID-19. OR equals 2.50. So that's NLR has taken both the levels of neutrophil and lymphocyte into account, indicating a more complete, accurate, and reliable inspection efficiency. Surveillance of NLR may help clinicians identify high-risk COVID-19 patients at an early stage. So my suggestion is that we may be able to use these markers as a gauge, a status level of our immune system. I'm suggesting that. I don't think anybody said that exactly, but for those of us that don't have it or concerned about getting it, but we want our immune system in tip-top shape, actually, what we want our immune system is in normal shape. Because right now, most of us, our immune system has been diminished. It's being hampered by our lifestyle, by the foods we eat, by eating too frequently. I mean, that's my understanding of evolution, is that we evolved with abundant fasting. And it's like we need it like we need sleep. I don't think that's too forceful to suggest that. Okay, so here's another one from July 25th, accepted date. Significant decrease in total lymphocytes and lymphocyte subsets, as well as the elevation of CRP, ESR, SAA, PCT, ferritin, and cytokines, but not IL-1B and IL-17, were closely associated with COVID-19 severity, implying reliable indicators of severe COVID-19. Okay, here's where it's really, they get into it. They're talking about systemic inflammation and infection. NLR has been examined as a predictor of bacterial infection, including pneumonia. This has revealed that the area under the curve, the C-index, the sensitivity and specificity for NLR were at a high level, suggesting that NLR is a reliable index of predicting the incidence of severe illness in an early time. Okay. Trying not to make this too long-winded, but nobody knows me, so I have to necessarily get into technical details until I establish some credibility. Okay, here's another publication. The dynamic changes in biomarker levels may assist in predicting disease course, prognosis, and outcome. Indications of systemic inflammation, such as NLR and SII index, or coagulopathy screening using DIC scoring system could be appropriately utilized to predict disease severity, possible complications, and outcome. Okay, so that's the 4 publications that, I think lend pretty solid evidence that the NLR is something we can reliably make use of. Now, the next thing that there's a osteoporosis specialist. He wrote a book, The Whole Body Approach to Osteoporosis. And many of the people, or some of the people that I come across online, have talked very favorably about his book. And in one section, he discusses how to utilize the RBC count. When the red blood cell count is even slightly low, it may indicate an accumulation of fat cells within the bone marrow. An excessive number of fat cells not only crowds out RBC forming stem cells, hematopoietic stem cells, but also leads to an increase in levels of PPAR gamma. Now, then he talks about MPV, he talks about RDW, HGB, MCV, and then he talks about NLR. An elevated neutrophil to lymphocyte ratio is an indicator of chronic systemic inflammation and is negatively associated with bone mineral density. NLR greater than 2.5 is correlated to bone density. So that's pretty interesting. We're getting some specific numbers here about the level of NLR that we should be concerned about. Okay, now I'll get into a little bit more about that with my own personal data. I worked up some of it in a into a graph format and a chart format using Excel. And I did have to spend about 2 hours to make all the common beginner mistakes with Excel. Where I would delete a whole column and then had to reinsert it. But anyway, so I'm making some progress. Now, there's a professor called Dr. Bin, B-E-E-N, and he has a really interesting recent YouTube discussion on galectin-3. And at this discussion, there's really useful comments. Once in a while you come across, like almost everybody in the discussion, I think there were like 70 comments or something, very knowledgeable. And one of them is John Caniglia. He commented quite a bit, and it caught my attention. He seems to really know about this galectin-3, John Caniglia. So anyway, I found a publication that I had shown this before, but I hadn't paid attention to the names. You can only absorb so much, But notice the first name in this publication. So this is pretty interesting. This is a systematic review of available literature. And they propose a dual mechanism by which galectin-3 inhibition may be beneficial in the treatment of COVID-19, both suppressing the host inflammatory response and impeding viral attachment to host cells. Okay, so this is from June 2020, June 15th, it was published. Now, one of the things caught my attention is he says the galectin-3 has been shown to activate the pro-inflammatory transcription factor NFK-beta, nuclear factor kappa beta, and induce the release of both IL-6 and TNF-alpha. Now, NFK-beta is one of the master triggers of inflammation. So, well, he goes into some detail about some of the neurological 36.4% of patients in this cohort exhibit neurological symptoms such as cerebrovascular events, impaired consciousness, and muscle injury. Additionally, a systematic review reports incidents of headache, seizures, asomnia, and an isolated case of Guillain-Barré syndrome. Now, there's a structural similarity between galectin-3 and the COVID-19. And he actually shows here's the molecular structure. So now this is just theoretical suspicion. I mean, they need to, but it's by somebody who studied this pretty thoroughly. So, and then he goes into detail about how suppression of galectin-3 simultaneously reduces the production of inflammatory cytokines while also increasing the levels of the anti-inflammatory interleukin 10, IL-10. And then he discusses some of the inhibitors like TD139, bellatectin, and there's a novel one, and he never mentions his modified citrus pectin, and which is actually quite frequent. I was starting to think that for a while it was just this is an anomaly of the Western research but I guess it's because unless it's been FDA approved, they want to stay squeaky clean and pristine. That would make sense, unless it's FDA approved, or they've done, stage 2, 3, 4 clinical trials. So I'm not going to beat on that particular item too hard. Okay, galectin-3 a novel blood test for the evaluation and management of patients with heart failure. Now this, Dr. McCullough, this was in 2011. Now he has a really useful YouTube video, I think it was 2015, which is actually, it's about 45 minutes to an hour. It's for medical professionals. So it's very detailed, very comprehensive, very technical, and it's just excellent if you want to become familiar with galectin-3. But what really caught my attention in this particular publication of his, where he's saying that because progressive cardiac fibrosis is believed to be a central aspect in the progression of both systolic and diastolic dysfunction, as well as the primary substrate for lethal arrhythmias, it is intuitive that a blood marker of cardiac fibrosis would be independently associated with heart failure, hospitalization, and death. He talks a lot about different. Okay, here's what really caught my attention here. These data strongly suggest that galectin-3 is a critical participant in the pathogenesis and progression of heart failure. Now I got to hold this up. So it's where the orange. So that means that galectin-3 is part of the cause. It's not just a marker. It's not just a biomarker. This suggests that it's involved in cause and effect, which, and I asked him, another orange mark. Cardiac fibrosis is an irreversible process. Therefore, galectin-3 measurement provides serologic overview of the cumulative fibrotic process in any particular individual. An irreversible process. See, this is where this caught my attention so much, was the with the gadolinium enhancement, they were finding scar tissue and fibrosis. The gadolinium enhancement, which makes it possible for the MRI, and then they're constantly improving that. So yeah, the level they're using at this stage is over 17.8. And there was another level, I think it was around 13 or 14. It's like, you better start paying attention. Okay, so that I think is enough for Dr. McCullough. Highly recommend. When they asked him what were the most valuable publications, this was in, I think, 2015. The reason he cited his own publication was because of this chart. Where he has all the studies, I think there were 13 studies done up to that date. And then he also cited the College of Cardiology and the AHA guidelines. I tried to dig out information at the guidelines. Well, boy, are they long. Okay, now, like I said, I was able to make some use of Excel, and I'm going to show the actual raw data, and then I'm going to show some graphs that I worked up. And I'm showing the raw data so anybody who's really interested in this and has the statistical, knowledge to, make use of these type of things, which I don't. I think I understand sensitivity and specificity enough to say that with the COVID-19, if the sensitivity is 100%, and let's say they test, all the children are coming to school, they have a 10-minute test, right? It's pretty cheap. It only costs like $1. Well, so all the students that test positive are positive. So if they find 9 students are positive, those students are positive, they have to be quarantined. Now, all the ones that tested negative, since it's only 50%, we've only eliminated half. Well, the next day, the children come in, they test again for $1 each, and once again, they eliminate half. So this is an extreme, even though it's not super reliable, it's extremely useful for, so anyway, here's the raw data that I worked up in Excel, and I'll just hold it up there long enough so people can, anybody that's interested in, and then I'll move up to the graph part. Okay, so with the graph part, I think we can see that the galectin-3 did drop from 11 to 8.4. That's a 23% drop in about 2 months. Let me see, that was the end of May. Beginning of May is when I started using the liposomal formulation of the modified citrus pectin and honokiol. And I was having some side effects that I was just feeling draggy, like I just, the way you feel when you have a cold or a flu, just feel like you don't feel like doing anything. And so over the next couple of weeks, I reduced the dosage. So I had started out taking 1/4 of what I would, because I've seen reports that sometimes the liposomal will increase the effectiveness by like 80 times. So gradually over the next couple of weeks, I reduced the dosage from 1/4 the amount to 1/9 the amount. But the galectin-3, according to Dr. McDougall, it takes several months at least, because it's a very stable substance. So he only checks it every 3 months or every 6 months. So that's another new thing here for this presentation, that the galectin-3 won't respond necessarily very quickly to interventions. Now, in case that data wasn't big enough, the most vital information, so I'm just holding it up. So now this is on record. It's archived at this YouTube video. And now, okay, here's the actual LabCorp reports. I'm just going to hold them up in order. So we have this archived. That was 9.6 in February. This is 10.4. That was then it went to May, it went to 11.0. And then in the end of July, it went to 8.4. Yeah, that was July 27th. So that was a 23% drop. Okay, so that's I've carefully archived that. The raw data is there, and I think I should publish something about this. But the data that's on file at LabCorp and Quest Diagnostics, that's reliable, impeccable data. But the actual interventions I did, that's not impeccable data. That's my own personal records and recollection of what I actually did with the modified. Now, there's another thing that I've been doing, but I did them last October and November, because I was starting to think that after 7 years of battling this elevated PSA, that there were fundamental aging processes going on here, which if I had any hope of getting reduced from a 30% chance of prostate cancer, was to address the anti-aging pathways. So it was back in October and November that I made use of the David Sinclair research with the with the NMN and the metformin and the but there was one other thing there. But I also made use of work by Vladimir Titarenko from Concordia University in Canada. He's had 3 or 4 really useful publications. In the one in 2016, they used some kind of robotic analysis to scour over 100,000 compounds that are on file, on record, that are available for everybody. And they narrowed it down and narrowed it down. And then finally they narrowed it down to 23 using yeast. And then they narrowed it down to 6 that work synergistically with each other. And they also work synergistically with resveratrol and spermidine. And the spermidine, it's available from Austria, but I haven't been able to get a source. But the resveratrol is easily available. And the other 6 herbs are easily available. So I made a liposomal formula with those 6 herbs and the resveratrol. This was back in October or November. I used the other one that I talked about with the NMN. And, it's betaine, trimethylglycine. No, it wasn't. Well, anyway, I made those 2 formulas back in October, November. So I feel that was way before, and my markers in December were pretty horrible. The main markers, the LMN, LMR, SII. At the time, I wasn't getting galectin-3 measured, but those markers were pretty bad. And then in January, when I started the modified citrus pectin, which was 3 months after I did these other interventions, that's when it really dropped a lot. And then I reduced the dosage, and the markers went up. And this chart shows how the markers changed. And I showed this graph in one of the earlier videos, but I'm showing it again because it bears on, because I'm using the SII, the LMN, NLR. Using these markers is, and then with the galectin-3, using those 4 markers is very useful for us. Now, I have some other markers here. I don't know if I should show them, but let me first, the controversy with the Valentina Puntman and Nahi, I forget his first name, that came out of Germany in late July. They published a correction, and not only did they find that the issues that were raised in Twitter feeds coming out of, I think it was Imperial College, Francis was posting comments about flaws in the publication. They found out that his observations were correct. They corrected them, and they found other flaws while they were doing this. This is the way good scientists work. They don't try to duck. They don't try to change the subject and talk about somebody else or something. This is great. This is good. But they also concluded that the overall conclusions remained intact. So here's this is the publication in the this was and they say the here's what Francis has to say. He says, I am delighted that the most important cardiology paper of the decade, according to the 9,000 plus Almetric score, is going to be corrected, he told MedPage Today. He sounds like a very outspoken young man. The revised JAMA cardio paper is brilliant. It's an all clear. The interesting features on the scans in COVID survivors are real, but they are caused by the risk factors, not by the COVID, he tweeted. He sounds pretty confident. that it's the risk factors. So now, Ira Cummins interviewed a pathologist from Germany who had autopsied 100 COVID-19 patients and concluded that they all died from the pre-existing conditions, not from the COVID-19. I don't know. I'm not an expert by any means, but discounting the COVID-19 entirely, I think that's going a little bit too far. And I actually have some theories about why that might be. But this is the TCTMD their report on the correction. Now, I look at their interpretation. They're quoting Francis in this review. I look at their interpretation being only correct for the out-of-date data, and I hope they agree that the new data is now fully reassuring, he said. I appreciate them for making it available so quickly. Okay, now here's where he gets into some technical. This is Francis again. The COVID-19 survivors have different heart scans than the healthy controls, but this is because of their pre-existing risk factors and not because of COVID-19, he said. Now, they questioned Valentina Puntman about this, and she said, she wasn't responding specifically to that. Francis also focused on the blood test results, which included some values that were adjusted as part of the collected publication. When looking only at high sensitivity C-reactive protein, HS, CTNT, and NT-proBNP values, Francis said there isn't much evidence that patients with COVID-19 look any worse in follow-up than patients with similar cardiovascular risk factors. Now this is where they got Valentina Puntman to address this specific matter. She says this discussion is good because it highlights the important gaps in knowledge, she said, adding that the biomarker data were mainly reported to show parallels with the CMR measurements, that the biomarker values aren't particularly high in the COVID-19 population makes sense given that they don't have the type of cardiac damage, such as MI or heart failure, that would result in highly abnormal blood markers. In our observations, we focus more on CMR measures because these have been more explored and similar changes have been related to worse outcomes in other inflammatory disease contexts, said Puntman. Oh, brother. Oops. But in any case, she's addressing that. I think what she's saying is with the gadolinium enhancement, they're measuring the fibrosis and the scar tissue. This is where the real damage, the long-term damage, not even any more potential, since we now understand the scar formation and the fibrosis makes the heart muscle like thicker and it can't pump as well. And imagine the scar tissue would make that, would exaggerate that particular malady even more. So now, this morning, Dr. Seheult, he's going into not this particular matter, but the matter of somewhere they reported that only 6% of the COVID-19 patients, only 6% of the deaths were directly attributed to COVID-19. And I didn't listen to the whole thing. I have this as like a front burner, but I could tell right away that his approach kind of like, it's participating. He used a hypothetical example, and he said, well, it was having to do with diabetes and some of the blood circulation problems from but the diabetes is contributing, even though they may say the person actually died from cardiac arrest, or like so much of it comes back to something else is contributing. So I don't think we can just dismiss and say it's all the pre-existing conditions. I think that's really a stretch. And I think a lot of people, including Ivor, and he had on David Feldman and Tucker Goodrich, and these guys are experts. And he had I think it's Everett, Nobel, and he had like 3 or 4 other experts in the modeling, and they're all saying it's almost unanimous. Now, with looking back, we have this data. We see the curve go like this. We see it go down. We see the lockdown, and the curve started going down 2 weeks before the lockdown. And then for me personally, I'm saying, okay, here's the lockdown. So we should see about 2 weeks later an abrupt drop if the lockdown is having that enormous effect. Well, we're not seeing an abrupt. The curve just continues. This is in a large number of cases. So I think people are seeing a lockdown. It's doing a lot of damage, a lot of these experts. So that may have something to do with that they're seeing the damage to the heart, the damage to the brain, lends ammunition to that alignment of forces that are in favor of lockdowns. So they've all discussed the lockdowns. They're all experts. They're experts in the modeling, the statistics. The thing that I've been looking at more closely and paying attention to is the super spreader events. Especially that, but I know they're going to say, well, the media is just harping on those things because it reinforces the lockdown. So maybe I better stay away from the super spreader events entirely until I have some really rock solid data on. I'm sure. Well, the reports I read about the big motorcycle rally in South Dakota, although I did go and look at the 2 week later, South Dakota, I think they were up 181% over the previous 14 days, which was by far the highest in the country over the previous 14 days. Okay, now, some of the other data that I arranged here to show is like, this people may find this interesting. Now, like, here's the changes in my neutrophils. This is the last 4. Here's the changes in the lymphocytes, absolute. Here's the changes in the monocytes, absolute. Here's the changes in the, that's PSA, that's not related to this. Here's the changes in the platelets. So the platelets look like a big factor. And then here's the changes in the EOS. I think that's eosinophils. So the eosinophils dropped a lot too. And then here's the galectin-3. And this may be the most important thing that, I may be at the cutting edge with this method to use the modified citrospectin and honokiol to lower the galectin-3 since, according to Dr. McCullough, the galectin-3 may be a direct participant in these inflammatory processes. So I think that's kind of exciting, and that's some good news. Now I have a bunch of other publications about galectin-3 and cardiac involvement. Like there were one publication cited 2 publications that demonstrate cardiac damage. So since this is apparently still controversial, here's one of them. And here's the other one that relates to cardiac damage. Now, this publication that I really liked, they also cited 3 publications that related to echo abnormalities. Echo abnormalities. So we have the University of Pennsylvania report about the 1 out of 3 football players with the cardiomyocarditis. That's the inflammation of the heart muscle. And that was on CNN. Yesterday, they interviewed a cardiologist, and he did refer to the publication of Puntman. And then somebody told me online that Chris Como, had a cardiologist on that was talking a couple days ago that was talking about the heart damage. So apparently this information is becoming more widely known by the general public that there's damage being done to a heart by this COVID-19. And they can tell this by examining it with the MRIs, with the gadolinium enhancement, late gadolinium enhancement, and they're also using a scintigraphy to even make it more visible. So I think that doing it, I talked about this in my other videos, the importance of strengthening our heart and obviously also strengthening our brain to be more able to resist, the fibrosis and the scar tissue. And also, possibly most important of all, that have our immune system, that we adopt a diet that makes it easier to fast. I never thought in a million years I'd be able to go 3 days without eating. And now in the last 6 months, I've done it 3 times and numerous times. I mean, almost every day I go 22 to 23 hours without eating. This has become a regular practice. Even if I'm a little bit hungry, it's not an effort, to eat one meal. And I'm getting closer and closer. But that fasting strengthens our immune system. So the keto diet is probably the most effective for being able to make use of fasting. And I've mentioned numerous doctors that, I mentioned if you're having a whole lot of trouble, Dr. Unwin of the UK, UNWIN, and Dr. Sarah Hallberg of the USA, they both work with diabetes. Reversal, and both are very successful. Dr. Unwin, his practice 7 or 8 years ago, he had the worst performance in the UK with diabetes, and now he has the best performance. And he had a publication. So people can go and listen to him. His wife's a psychologist, and she's helped him to be more effective. In persuading his patients, he only gets 10 minutes. And what he often does is he'll ask his patient to recollect some challenge they had at an earlier point in their life, maybe when they were a child even, and what they did personally to try to address that difficulty, to try to achieve that goal, to try to overcome that challenge. So that's maybe an idea for people, because what I do may not work for you as far as making these big food changes and making use of fasting. So now, I think that these papers more or less are related to the overall heart damage. This is the one I like the best. Now, they were able to determine which types of cells in the heart were actually being damaged. And of course, it's the ones that have that receptor. And it was happening in cardiomyocytes, but not endothelial cells or cardiac fibroblasts. And they built a model so they could actually test some of their ideas, and the model was effective. And then later on, they compared it to the actual cells from autopsies, and they found, similar results. And there were unexpected things that came up. Altogether, these results indicate that SARS-CoV-2 is able to readily infect, replicate in, and rapidly propagate through CMs, which are the cardiomyocytes. Yeah, I spent quite a bit of time on this one, and then I went through all the references they used, because they got a long list of references, 44. So yeah, you can see in yellow, these are the ones I found the references, printed them out. The ones in yellow, I printed them out and reviewed them some. There's one more. So I feel like I need to do things like this because nobody really knows me. Like, why should we listen to you? And so, but because the interventions I did for the prostate cancer also apply here, right? So it's like I feel like I'm at the cutting edge, and I need to share this. And I'm certainly not selling anything. We're in the midst of a crisis here, so I'm just sharing, this information. I'm not a merchant. I'm not a salesman. So anyway, the other publications were related to that, to the heart damage, kind of bolster the. I'll just show a few of them. So many of them are recent. This is August 21st. This is August 7th. So, I think that I've covered anything. I don't think I've forgotten anything. This is Nagel and Puntman's actual comment and response. Okay, so I look forward to some comments, and I hope that people find this useful to get prepared. So thank you for listening.